And so now I really have my anatomy. So I've got my V3, I got my superior, I got my arcuate eminence, I have GSPN, I know where everything is. And move forward. And so now I really have my anatomy. So I've got my V3, I got my superior, I got my arcuate eminence, I have GSPN, I know where everything is. I dissect and move forward. And so now I really have my anatomy. So I've got my V3, I got my superior, I got my arcuate eminence, I have GSPN, I know where everything is. I dissect and move forward. And so now I really have my anatomy. So I've got my V3, I got my superior, I got my arcuate eminence, I have GSPN, I know where everything is. Looking at the root entry zone of the trigeminal nerve and brainstem only, you won't see the preponderant system. So now this looks like a picture we all recognize. V3 features apex. We'll start drilling that medially. We'll finish that drilling, and then we're going to open the dura over Meckel's cave. The features apex. We'll start drilling that medially. We'll finish that drilling, and then we're going to open the dura over Meckel's cave. The features apex. We'll start drilling that medially. We'll finish that drilling, and then we're going to open the dura over Meckel's cave.
Um, Ah.
Oh, what's going on? I was looking for headphones for like regular headphones.
Do you hear us, Dr. Borba?
No, it's getting connected. Now I can hear. Hello, can you hear me?
Yes.
Now I can hear you also. Okay.
You have to get new AirPods.
I tried.
Agora tá.
Agora deu?
Agora deu, foi.
Beleza, então. My wife is saying that so speaking Portuguese. She speaks Portuguese. Okay, my friends, I'm sorry for the confusion, for the delay. I was in surgery, and a pleasure to be here. A pleasure to be with the University of Miami, our friend Dr. Almefti, and the whole family, Dr. Georgios, Carolina, and our boss, and Dr. Morcos. Okay. Let's see if can you see my screen now? Good.
Perfect. Just put it on the presentation mode.
Good.
Excellent.
Okay. some years ago, you talk about trigeminal schwannoma, there are no other option. Go there and take it out. But that time, there was no understanding how the tumor behaves. Was tumor in the middle fossa, many people do paternal approach and go there and see the dura. And open the dura, you go inside the tumor. After the tumor, go in the posterior fossa for the tumor that's in the posterior fossa. Retrosigmoid approach, I cannot go to the middle fossa. After start to come new players in trigeminal schwannoma. Trigeminal schwannoma is not so often. It's a hair tumor. It's 0.2% intracranial tumor and 8% intracranial symptom. But the patient has a lot of pain, has a hypoesthesia, sometimes hearing loss, sometimes facial palsy for the middle fossa, from the Gasserian ganglion, geniculate ganglion, as Dr. Kate just showed. It can be in the infratemporal fossa, can be in the lateral wall of the cavernous sinus, invading the lateral wall of the cavernous sinus, can be just in the petrous apex, can be in the posterior fossa, or can be in everywhere. This is the picture from Dr. Lefty paper about trigeminal schwannoma that show how is the growth pattern of the trigeminal schwannoma. Do you know that everybody today talk about vestibular schwannoma, 100% of facial nerve preservation? I don't know why. It's not true. 6% preservation of hearing, and sometimes tumor like this, and they preserve hearing. And the guy that is starting neurosurgery said, why? I'm doing surgery to save life. And these people is preserving everything. But vestibular schwannoma has an issue. The facial nerve is an issue. Of course it is. See? Nobody talk about facial. But what's wrong with vestibular schwannoma? Trigeminal schwannoma? If you just follow the anatomy, if you understand the tumor, why you should give alternative treatment as radiation therapy, different modalities. If you can go there, remove the tumor, and many, many times save the nerves. We know that radiosurgery or other kind of modality, the tumor regress. Not will disappear. The tumor is there, some tumor is still there. And 50% doesn't change. And 16% increase in size. For a benign tumor, that you should just learn and understand how the tumor is. I always like to remember in the 60s, in the 50s, when the people was going back, the Jewish people was going back to Israel in that area. In the tinea capitis was treated by radiation therapy. Very low doses, very, very low doses. Today you need some brush. In this tumor, if this patient get a radiation-induced meningioma, it's very rare, but often it's happening. See? It's rare, but often happening. All of us have a case of radiation-induced meningioma, or to treat leukemia that we used to take, or to treat brain tumors. See this guy, this young guy here, medulloblastoma, there is no more tumor here. Some years, the tumor there. Radiation is good, Gamma knife is very good, works, the tumor decrease, but we cannot talk about disappearing the tumor. One advantage of the surgical treatment for trigeminal schwannoma is this, is immediate pain relief. 100% of the case. It's very rare to have patient has pain in the post-op, you remove the tumor, the pain gone. This is the literature says, not me. Maybe one of the most important issues in the treatment of trigeminal schwannoma. We should understand where the tumor is located and decide the approach based on the location. But more than the location, should know the anatomy of the nerve. Remember that the nerve in the middle fossa is extradural. When the nerve passes here from the polus trigeminalis is intradural. When the great majority of the tumor arises from this area, from the Gasserian ganglia, and can go posterior, anterior, and down. And if you follow the tumor, you can do this. I just saw last operative neurosurgery, I think 2-3 months ago, operative neurosurgery. Very nice video. Very nice video. Surgery for trigeminal schwannoma, beautiful. Middle fossa first, after posterior fossa. Retrocede. Why? If you are there in the middle fossa, you see the tumor in the posterior fossa, why are you going there? Why should I stop? Why should I not follow?
Why should I not follow?
This is shown in the literature.
This is shown in the literature. When you use the skull-brace approach, you have 90% of
radical removal.
Total removal. Radical removal. Total in skull base is a word that's a little bit difficult
the
to
conventional standard approach, like
and the conventional standard approach, like terminal approach,
sometimes the only retrosigma,
and sometimes the only retrosigma approach. In 60% you can take it.
There is one area.
There is one area that changed a lot in the last years. Is the Petros approach. And the one approach that you learn more and more and more is the anterior Petros approach, as Dr. Kate Almefi just showed beautifully.
We should understand the anatomy.
You should understand the anatomy, not only the nerves and the artery, but the bone.
Very interesting. Why the people from Asia, they use a lot
middle fossa? Because they have a very large Petros apex.
Latin people who don't have too large like Asian people. They have a big avenue here. In this avenue, you can work around. See, and the CT scan can give you the information how you can get and remove the tumor. But what the trick to take this tumor from the middle fossa? It's easy. Go to Netflix. Okay? See this movie from Loud Market. Just follow the money. The money is the middle fossa. Just follow the money to the posterior fossa. And the tumor will give you. And the most important, the arachnoid will be outside the tumor. I will show you in the next case. This man changed the history of this approach. Professor Kawazi. Professor Kawazi, you know how he found out how to do this case? He was trying to open the internal auditory canal for the middle fossa. And when he was open, he was always wrong. He was going to the posterior fossa. He was seeing the basilar artery. He said, oh, if I take the Petros apex out, you can go and follow and have this approach. In this picture, Professor Kawase, he represents here a meningioma. See? But the tumor that's suitable for anterior petrous approach is the trigeminal schwannoma. He used this incision. See? Some people use just straight incision. See? One point, and it's very important when you do skull-base surgery. Before you open, you have to think how you close the hole. This is the article by Professor Omefti in 1990. He used this to approach the infratemporal fossa and sometimes the middle fossa. The most beautiful idea and the smart idea have you ever seen. Look at that. You come here, you cut the zygoma, you identify the temporalis muscle, you go to the coracoid process of the mandible, you cut the coracoid process of the mandible, you elevate the temporalis muscle, you do the surgery, you remove the temporal, you put back. It's amazing. What's the problem with this approach that Dr. Omefti never more used? How to close the cavity. And to close the cavity, you need this friend here, the temporalis muscle. And you need fascia, temporalis muscle. And always you have some leak. Always you have some leak in the dura. Some small hole, always you have it. It's difficult to close. And the best way to separate the dural compartment to the paranasal sinus into the area to avoid is vascularized flap. The same that you do from the nose, you should do from the head, from the anterior part, from the posterior part, from the inferior part. Because this, the petrosal approach, you should plan before do it. You can change the incision, you can make smaller, you can make straight. I prefer to do the incision like this. One trick for the young people, see, use the knife to up. This way you keep this fascia here of the temporalis muscle, and you rotate the fascia of the temporalis muscle back. Then at the end of the surgery, it will rotate down, and you cover the whole skull base, the middle fossa. This is to avoid the most common complication in skull base, the CSF leak. Sometimes you cut the zygoma, sometimes you don't cut the zygoma, depending on the shape of the head. See, if the patient has long middle fossa, sometimes you need. If the tumors go up, not down, tumor go up, maybe you need to cut the zygoma. See, another trick for the zygoma cut. Put first the plates. It pull this back. See? And put the temporalis muscle down. See? The way that we learned from Dr. Paulo Cadre that published Dr. Omefti to preserve the fascia. And from this part here, you can see, you must see the two holes. One cut here, another cut here. You should see this part, you are in the maximum exposure to it. And do a simple temporal craniotomy that you do every day. See, I prefer to use in this part the cutting burr to go more down. See, and that's very simple. See? Not skull-based approach, you have to say, to drill everything, but the skull-based way to do a conventional approach. And at the end, this fascia here, you come down here and cover the skull base. Let's show a case, very simple case. Small and trigeminal schwannoma. Today I do a smaller incision, maybe craniotomy a little bit smaller. You go to the middle fossa, identify the middle here. One trick that I'm using now, I'm going first to the frontal base, take a lot of CSF and relax the brain. Lumbar drain, I don't use lumbar drain. I do this technique. Go on the frontal lobe, under the frontal lobe, carotid system, take a lot of CSF and we release. Use a lot of glue. See, it's very difficult to coagulate. Go and do the peeling of the middle fossa. Peeling is peeling. Peeling is not cutting. Peeling is peeling. See? You leave this, the great superficial petrosal nerve. If this bend, now here one trick that I learned from the most difficult and hard way. Dissect the great superficial nerve from anterior to posterior, never from posterior to anterior. I had a patient with facial palsy. Man, you do a middle fossa. If you approach, the patient has facial palsy because of the approach, you're gonna die. See? But what's the trick? Find V3 and come this direction. What's the trick to drill the petrous apex? Do a small hole inside and go widen. This way you can see the dura of the posterior fossa, the dura of the middle fossa. The maximum exposure you get when you release totally the five, you can mobilize the five in the case of meningioma, or for trigeminal schwannoma, you can follow it from middle fossa to the posterior fossa. Another trick here, superior petrosal sinus. If you want to put glue, don't put glue back. Put glue to anterior part. See? If put back, the glue can go to the sigmoid sinus. I learned from the hard way. How to dissect the nerve. Dissect in the direction of the fibers. See, in this direction, not like this. It tries to open, no, onion. See, ceboja. See, onion. See, you go peeling, peeling, peeling. See, and the tumor will appear by itself. You can do this for a small tumor. You can do for large tumor. Go inside, decompress, decompress, and open. This way, you can save some brains, and you never know if this nerve will work or not, but at least try. At least try. I have seen people show nice videos and cut the nerve there, cut the nerve anterior, posterior. Let's try to save some nerve. Maybe it work, maybe not work, but at least I try. See? In this way, see, you can take and remove the tumor. I can follow this from the middle fossa to the posterior fossa. Avoid coagulation is one of the tricks to trigeminal schwannoma, for vestibular schwannoma, and for meniscal-based tumors. Avoid coagulation. Sometimes bleeding, but you learn to work sometimes in the past. You remove the tumor. Now I put the fascia. You put the tumor back to make the picture. The people like it. See, it looks like you are doing surgery. And now you follow from the middle fossa to the fossa. I didn't see the brain. I didn't open the dura. I just followed the anatomy. In this case, I use fascia lata. You can use dura substitute. And after that, you rotate the flap. If you learn with small tumor, you become more brave. You can do with another one. This is the way a tumor that today I do different. This I did many years ago. I was afraid to peel the tumor from the cavernous sinus. I think today the tumor can do from the nose, you know? You go inside the tumor, you can find the plane easier. I think the best way in the a bit less invasive. Less invasive you can do from the nose. I did peel of the middle fossa. I came from up to down. Today, If I have a case like this, I do from down to up and just follow the tumor. You see the cavernous sinus will be in the superior part. This is the case that I told you, just follow the tumor from the middle fossa, follow this direction, working inside the tumor, and just follow it. Is the way to do the surgery. The same situation like this. Oh, it's closed here. You cannot do the posterior fossa. You can wide. Open the porus geminalis, cut the tentorium, coagulate the superior petrosal sinus. Open the tentorium, you open the window. Go inside the tumor. Decompress a lot, and peel the nerve from the tumor. You start to do this, you can go from the middle fossa to the posterior fossa. You see the posterior fossa there, the intradural part, to the basilar artery, with the V3, the V2. You just follow it from the anterior part to the posterior part, and prep and toss up. Another situation, same thing. This video is published in the operative neurosurgery. See, you can see this here. This is a long video I go on a long time. But sometimes when you start to do something, you become brave, you know, and you think you can do everything. What is the logical way to treat this tumor here? The logical way is coming from the rectal seat, not from the middle fossa. Don't know why. Look at this. You have a very small tumor here in the middle fossa. You have a very large tumor in the posterior fossa. But you will work between the nerves sometimes. And you have to cross the arachnoid and follow it, maybe open the porus geminalis from the posterior fossa to the middle fossa. It's logical. But I try to do this from the middle fossa, do the same surgery, cut the middle meningeal artery, do the peeling of the middle fossa, separate the dura. See, it's a little bit faster here. See the Gacherian ganglion, have some CSF leak. CSF. You dissect the tumor that is in the middle fossa. There's a small tumor there. I release, take CSF. Now I drill the petrous apex, the small hole that now is a wide hole. See? You can come from time, identify the superior petrosal sinus, you can coagulate, you can put surgicel, you can put glue to the anterior part, not to the posterior part. You liberate totally the 5. Now I follow the tumor. See? From the posterior fossa, from the middle fossa to the posterior fossa. See? And parallel to the base of the skull. This one is the trick for the middle fossa, see? I see the people doing middle fossa, they sit like this, the head in front of them, one spatula here, other spatula there, do a skull-base approach, and take the brain out. Move yourself. Move to this direction, go to another direction. You can move around of the skull-base. Use the window that the bone gives to you. See? Now we are going to the posterior fossa and just peeling like an onion. In the tumor and the layer, you start to see. You see the basilar artery here. What's the trick to stop this small bleedings here from the vein? Just glue. See? Now you go small, you go around, dissect a small branch that's around the artery. Separate the small branch and go in the direction and open, decompress, and keep the arachnoid to the nerves, to the vessels. Protect it. It's different. Skull-based surgery for tumor and for vascular disease. It's different technique. For skull-based tumors, you leave the arachnoids to the vessels and to the nerves. In the vascular case, you dissect totally the vessel and see clearly. You see, we try to keep this arachnoid in this direction here. So this is there. And now we are going separating slowly from the middle fossa to the posterior fossa, and the whole tumor, you come from the middle fossa. You say, whoa, where is the fifth nerve? Somewhere there. Let's see where is the fifth nerve. See the arachnoid there, the basilar artery here, the fifth nerve here. This is more bleeding from veins. You use some glue. In our fourth nerve, where is the fourth nerve? See, in the middle of the arachnoid. I don't need to go there to see the fourth nerve. We know where it is. Separate. With the sixth, look the five, from the posterior fossa to the middle fossa. Just follow it from the posterior fossa to the middle fossa. Use the fascia of temporalis muscle with the posterior part of the temporalis muscle to close in the post-op. See, the patient has a slide 6 here. See, in the post-op, immediate post-op, not 6 months later. And the pre-op and the post-op. Just follow the money you can take. Today, I don't know what we are changing. I don't know if we are going to better for the patient, better for the doctors, better for somebody else. But for trigeminal schwannoma, for a benign meningioma, for a benign vestibular schwannoma, for a benign tumors in the skull base, the best way to go there and try to remove. Sometimes you can, sometimes you cannot. But at least try. At least try. And the idea for the trigeminal schwannoma is to understand how the tumor is, how the tumor behaves, how the pattern of growth the tumor is one of the most important things. Most important thing. If you understand the tumor, you understand that the approach, you understand the way to treat this tumor. I always like to finish our presentations like this. Many of our mentors learn neurosurgery in the head of somebody. It's not our way to learn neurosurgery. There is no way to learn skull-based surgery. There is no way to learn any kind of approach if you don't go to the lab. I did course more than 15 countries around the world. Every year, I'm proud to go to Dr. Amefti course in St. Louis. I go there to learn as a student, to learn every day. I saw Dr. Amefti dissect. I learned something different, you know. He's always changing. He's like wine. He's getting better year by year, you know. And the course is not to do like this. You go there to see, take the head, do the approach, and go back home and try in the first case. No, you go back home and open your mind. You go to the anatomy, you go to the medical school. Oh, these cadavers in the anatomy are very bad. But we are there to learn. We're not there to make nice, beautiful picture to publish it. Nice dissection like Carolina does in Miami. She's a teacher. You go there to learn and help the people. In the skull-based approach, the only way to learn is like this. Our meeting is changing. Rio is still beautiful. The COVID, one day will go, and we hope in March 22, you can meet in Rio to talk, discuss, and have fun around this Calvary session. Thank you, Carolina. Thank you, Professor Marcos. Thank you, Kate. And sorry for the long time in here. Thank you.
Dr. Borba, excellent talk as always. I mean, your videos are just fantastic and the pearls are endless. So we are looking forward to having you in one of our lab sessions. Hopefully we can coordinate now that whenever they open up the borders from COVID. So
yes. Now I need the quarantine.
Yes, you have to go to excellent. I just want to remind the audience, if you have questions, please feel free to put them in the Q&A and we're going to get to them shortly. David, do you want to share a quick case?
Yeah, that'd be great. That would be great. I'll share my screen here. All right, well, it's an honor to be able to share this case with our panelists today, and very grateful for the opportunity to be here in Miami for the upcoming here with Dr. Marcos and Dr. Benjamin, Dr. Ivan, Dr. Stark. Thank you very much. Dr. Benjamin shared this case kindly. It's a 57-year-old female who presented with 2 weeks of headaches and visual decline. You can see her exam listed here. Her exam reveals severe visual dysfunction, particularly in the left eye, 20 out of 300, and bitemporal hemianopsia, left worse than right. Fundoscopic exam reveals pallor on the left-hand side, and the rest of her cranial nerve exam is normal. Here's her preoperative imaging, which demonstrates a heterogeneously enhancing suprasellar mass. I'll turn it over to the panelists.
Go back to the images there, David, and see what the panelists think about that and what they're thinking when they see something like this. George, you want to start?
Sure. I think this appears to be like craniopharyngioma. Can you hear me?
Yeah.
I'm sorry, David. How old was the patient?
57 years old.
This looks like a craniopharyngioma. Obviously, you have to have keto white differential. Something like a adenoma that may look very typical, but it doesn't look like that at all, or something inflammatory. Again, it doesn't look like that. So it looks very much like a craniopharyngioma to me. I don't know if there's any CT imaging or any indications or.
We did have some calcifications on the CT, so it was sort of very your typical appearance for a cranial. What are you thinking when you're? I mean, I think I know what you're thinking, but how would you approach this?
So one.
Oh.
Next up, let's paint.
Hey everybody, welcome back to the live edition of Let's Paint. And for over 5 years, public As the woman asks the clerk for wart medicine,
Yeah, so could you help me with that?
sure, the man sneaks behind the counter.
Don't worry, I'll distract him with my hotness. Excuse me, where can I find wart medicine?
After that, can I get your number? This is a sexy conversation we're having.
Okay, so, all right, so I'm sorry, so is it before
He's got a lot of energy for a smoker.
Okay, so, I'm sorry, that guy had one of every brand. Where's the loyalty? Do all sorts of stuff myself, too, you know, like I turn it over, match, cut it over, like, yeah, no, that went up good. No.
Quick, go steal bigger trash bags.
And now it's like an angry war, you know what I'm saying? It's like, he knows I was messing with it, so it's like,
Keep talking, babe. Keep talking. Are you just gonna kick 2 dozen cartons all the way home?
yeah, the way you're describing it, it's like, put onto it, it's angry at,
Keep talking, baby. Keep talking.
Police put out an APB for a chain-smoking man and a woman with bumpy skin.
Maybe next time you buy the cigarettes and steal the wart medicine. See how that goes. Trial and error. Same way as you make the light bulb.
you wanna take a look at this, sure?
Oh, no.
You sure?
Yes.
Okay.
I did not so well, and I walked in and I looked my car on purpose. And I walked a quarter mile from here. They weren't sure.
Call 911, you want tacos?
Yes.
Everyone gets our best deals on all tacos. Scott, entrepreneurs and small business owners, I'm about to show you a weird, almost backwards, funnel secret that
I was invited to a show for you in Baltimore next week.
Right now, on South Beach Talk.
I got a lethal order, it's time sensitive, grab her knees and get.
together.
Apparently this works best if the hair you're trying to remove is invisible.
With a simple twist and roll action, hair is gently removed from the root, leading to smoother skins and long-lasting results.
Ow! I don't have any hair.
I gave our baby her first hair.
Nice episode, that's right. Today we're at New York Cake, and there is a cake decorating contest being held here.
You'll be posing as the judge and slightly ruining the contestants' cakes.
That's right. A slight ruin.
A slight
Welcome to the New York Cake Academy Challenge.
This is a serious cake decorating contest here. They've given 1 hour to decorate these cakes. These contestants are competing for $500 and entry into the biggest cake competition in New York City. And they're being judged by the man who knows cakes, Brian Cucoin. Start judging.
Ooh, hello, what do you have here? This is lovely.
The theme of this contest is New York City. She's crushed it.
Ooh, hi, Dougie.
Pleasure, Elijah.
Hi, Ashley. Hi, Ashley. I'm KP. Hi, KP.
Listen, I want to donate back to my city, so
Yeah.
charity.
Are you guys from Detroit? We are from Detroit. So we want to get rid of these things.
Basically, I need a receipt for my tax write-off. What you about?
I want to say about 15,000. For a contract. I can't do that here. But my friend told me that you guys are taking donations. Okay, so here's what I can do for you. Is there a certain charity that you like to normally donate? Why does it matter? Because what I can do is I can make a phone call and have them pick it up from here.
That's the point of me coming here.
But we're a contract.
Right, so what I need
So
to
what
do.
you can do is you can leave it here.
You're interrupting me.
You are very rude. I don't know why these people came here. If you want a tax write-off, this is not the place to get it. We're not a charity, and this coat is worthless.
What I'm saying is, I need a receipt to show
Who's the one getting loud here?
that this is worth about 12 to 15,000.
I can't do that for you. We're not a place that. You know what, bitch? Why are you stuttering? Do you know your job? Wait a second. Wait a second. Bitch, number one, my face. Number two, number and number four. Bitch. Really? Really? Have a good day. You sort of my face?
What you gonna do?
You just sort of my face? We did. You sort of my face? You should calm down. You sort of my face?
Hold on. You serious right now? You know, Ashley's been giving me about my watch here, but it doesn't matter. Nobody's gonna disrespect my daughter. It's time to go.
Have a good day, Ashley. Get the heck out of my store.
Hello?
This store is a bunch of crap. They should have been somewhere else for their tax write-off, but I actually know this one is worthless. Keep the coat. That's why they left it here. Hope they give to a good charity. Bitch.
How you doing, guys?
Hello.
I'm looking like that.
Okay.
Maybe something.
Okay. Perfect. Hey, there are more. Looking to upgrade his little lady's ring. Hopefully we can help him out today.
So what do you got?
You see this ring? So you want
I can take it off. Will we take it off?
Yeah, that's fine. That's fine. You want to go with the marquee? You want to stick with rounds?
Who did you text me?
Like, I'm worried about it, man.
You want to spend about $2.
Who is Tina?
You ain't never my cousin, man.
Are you serious? Your cousin? 7 years. You ain't never brought up no Tina to me.
Oh, she tripping, man. She's my cousin, man.
Whoa, looks like there's trouble in paradise.
I ain't got time for
Whatever. What you gonna do? What you gonna do? I ain't been with you. What you gonna do? No, whatever. You don't keep playing with me. Do whatever. Come on, let's go. Let's go.
So we're not interested in the ring then?
Get off.
You're not acting grown. You're not acting grown.
Baby, keep walking. Keep walking. These kids aren't gonna make it. Baby, you're home. Would you calm down? Calm down. They don't need to do any more ring shopping. They just need to go their own ways.
Last week, and I seen this horse that y'all would get taken again. How'd you pay?
Cash?
Cash. How much did you spend?
I spent a lot of money on that thing, man.
Okay, number one, I'm not swearing at you out of respect. I would appreciate you swearing at
I'm
me.
a little frustrated. I spent a lot of money.
How much did you spend?
I spent a few $1,000 on Rolex.
This is the box that came in?
Yeah.
Okay. Did you remember this?
No,
You can see that, right?
I can see very well.
This is fun.
You guys must have written the box.
It doesn't say Rolex on the watch.
Back up out of my face.
Or what?
Why don't you back up out of my face?
This guy was cool. He will at any second. I just want to give him as close to the exit as possible. Come here. I'm going to show you where your Rolex is. Okay, come here. Come here. I'm going to show you exactly where your Rolex is. And by the way, if you wear a tank top, I advise you work out some more. So come on.
Face.
You what?
I'm gonna work your face.
Really?
You probably don't know. I'm trying different martial arts. I don't play when it comes to singing.
Get out.
I want what I paid for.
Here you go. Catch.
I want what I paid for. Bitch.
He does not take threats lightly. Period. Come on.
Where is I came up here to talk to my girlfriend.
Deposit on what? Layaway?
Yes. Her first name is Julio.
And when was the last time she made a payment?
Oh man, I don't really know. She just told me to come down here and pay something. So I'm just going off of that.
Okay.
And if you can like hurry it up, then that's better.
I can. Hurry up.
Okay, you ain't gotta stop your fingers, you know.
I was just imitating.
Okay, but you ain't gotta go that far. You behind here.
Oh. Okay.
I don't really have all day.
Okay, what first name again?
Bonita.
Okay. B-A.
B as in banana, like we're trying to get you to spell. A as in apple. Nut.
No.
Wait, nah.
What is no?
No. As in, if you don't hurry up, nah, I'm gonna get frustrated. Nah.
So, okay. I don't have anybody in here with a Bonita.
You can't spell Bonita.
You know I'm so frustrated? Why are you smushing your face against my window?
Right.
Get your face out of my window!
You're right. You're not.
I'm done.
Look, you can't be done.
I'm done.
Okay, no,
Bye.
I'm done. Hold on, no, hold on, man.
Time to go.
I just came in here to get my. You can't spell Bonita.
Dude, if you don't know how to spell your girlfriend's name, I don't know how to help you.
Bonita. That's it.
While my dad's out dicking around with $2 watch bands, I'm gonna make some real money.
How many horsepower you got?
A lot. 600 cc's, my man. Just got put on for today.
How much you want for it?
2,500.
I'll see what it's got. Now get the keys. I want to see if it starts.
I'm not turning it on here, but if you want, we can take it outside.
I'm sitting here for just butter. You gonna let me get it up down the road, see what it's got? I want to see if I can get it down the road.
Unfortunately, I can't allow you to take this anyway, unless you put a deposit down.
You can't let me take Mike down the road. I feel like I don't have a right to Mike.
Put a deposit down.
No, I ain't gonna put no deposit on it. I just want to ride it up down the road. If I like it, I'll buy the bike.
Who's this guy?
That's my dog.
That's your dog?
That's my dog. You got a dog that bites? I got a dog that bites too. Somebody give me the key to this bike.
Give him the keys. I give him the keys.
I'll roll out myself. Somebody better bring me the keys.
You take it off the stand?
Why? You got somebody to go stop me? I don't need your dog. Come on, dog. You get over here and take care of this light work over here. Yeah, I got a helper too. I got a helper too. I got my It don't matter what I'm home, man. You stay out my face. That's all I can say. Sure, you say something. You should go. You get out of here. Put the money out here. Come on, man. Yes, sir. Now, get out of here, man. He had no refer to me as a dog. It's had a big bark and a big bite. So I pushed both of them out of the door and flew like bird. Have a nice day, sir. Kiss my ass.
Hey, how you doing?
I'm good. How are you
I'm doing fine. Well, I'm here today because I have my grandma necklace. The necklace has been in my family for years. You know, I'm trying to see what I can get for it.
Sure.
Now, how much is it? I'm looking at least about 2,000.
2,000. What do you need the money for?
Just a little extra pocket money.
The problem with it is it's not real.
Which means
This is not gold. As you can see, the color's coming
no,
off.
no. See, jewelry cleaner would do just a perfect job on this.
It won't because this is copper.
That's not copper.
It is.
This is just bling. Look at it. Look at it.
I did.
Can I look at it? Sure. Let me look at it for a
There you go. That's copper.
That's not copper.
It is.
You know about jewelry?
I do.
You sure? Because I know my jewelry.
Really?
Yep.
What is this piece called?
That's the magnifying glass. What is it called?
A jeweler's look.
Huh?
A jeweler's look.
A jeweler's look. I don't think so. I beg to differ.
You're entitled to your opinion.
Yeah.
I do know my jewelry.
Well, I need some money, man. What can you give me?
I can't give you any money.
You kidding?
No.
You kidding? You kidding?
Serious.
No money, no nothing, no trade-in, no pawn,
Nothing.
nothing,
Nothing.
nothing,
Nothing.
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 Matter of fact,
Nothing.
I'm not leaving out here with no money. Give me somebody up there He's gonna help you find something. Man, you don't know about Jerry, man. I don't know how. You don't know that, dog. Jerry, I never got him.
Next thing along.
Come on, man. Oh, no. This is not going to go. This is not going, my man. You just not so, okay. Man, it just came out of it. What's up? What's the problem, man? What's the problem? What are you doing?
I'm sitting here checking out this here couch, you know, and my man walks over, knocks over the lamp. I picked it up for being a nice guy, protect y'all's establishment. My man blaming that on me.
Well, so if you didn't break it and he didn't break it.
Sorry, not over, but.
This guy broke a lamp. That means you have to pay for it.
We're gonna buy it?
No, it's broken. You got any money on you?
I'm not paying for the lamp. I'm crazy, mother.
How crazy are you?
Crazy enough.
How crazy? To do what?
Check.
To do what?
What? The guy is completely out of his mind. What the? We're gonna take it so far before you've got to go. Get out of here! Get out of here! All right, it's time for me to go.
I got so. The guy needed help. My family. Assistance out of the door.
You can take a swing.
Well, I see you got taking the shirt off.
I knew.
Yeah.